things. But it's so wonderful to be with you, and we have such a common ground in terms of our just passions for making change in women's health. We met actually at the launch of the Women's Health strategy and initiative, and I was blown away by your speech, and then we basically fanned over each other because we were both there with passion to speak about women's health and how we felt change should be implemented, but more so not just talking about it, but making action in what we do in our everyday lives. And I think that's really what motivates us, is hearing stories every single day from people, from their struggles, and that's what really keeps you going to want to make change.
Yeah, no, thank you so much for inviting me, because we did definitely connect at that event. And I thought that this is what the work that you do, because you do molecular genetics, and also you're the co-founder of Fertility. And I thought that's an amazing way to bring tech into how we educate patients. And if I'm completely honest, from a GP perspective, infertility is something that we don't get taught much about. And so the opportunity to come and do a TikTok live with you, I was like, yes, we need to do this. And somehow I wanted to also get some myths out the way as well for you. Because, so I'm going to interview you.
Okay, I'm not.
Because I want to ask you those questions.
Yeah.
So one of the things that I thought that we could do is that lots of people who are watching, who are probably struggling with their falling pregnant, or have fallen pregnant and sadly miscarried, or had baby loss later on down the line. And then I wanted to tackle the cultural aspects that I see. And I wanted to draw out some data with you. And finally, I wanted to sort of just do some final myth busting, if that's okay.
Yeah, great.
So the first question I wanted to ask you is that, how should a patient go prepared to their GP if they're struggling to fall pregnant?
It's a really great question. And I think what we've actually even witnessed in terms of our data is that different cohorts of individuals access care at different stages. So we know, for example, for women who will do a fertility test, Black women will access or will decide to go and get help much later. And we don't know quite why this is. And that's why I think it's important to have this conversation around not just what should one do, but given one's circumstances and their background, we actually underestimate the pressures and the conversations that people might be, or resistance maybe, that people might be facing. That may be resistance in the form of people saying, you'll be fine, or resistance in the form of people saying, you're so young, don't worry about it, or resistance in the form of people saying, you know, you've got time. It may also be resistance in the form of their own, I guess, doubt or reassurance. Some people doubt everything that they feel, whether it's symptoms, whether it's pain. They're like, I'm probably fine. And so we're big victims of dismissing our own symptoms. But sometimes when we actually do take up the courage to say, I think I need to go to the doctor, the response will be, you're fine, it's okay, everyone experiences this. So to me, I think it's a very personal journey as to what someone should do and when someone should go to the GP. I guess in a strange way, from our perspective, we created fertility to exist outside of the need for a GP. And I think the reason we did that was because in ways it's very unfair to expect you, a very busy, no matter how intelligent you are, you're busy, you see lots of patients, and you have a short amount of time with each patient, which I know from speaking to you and many other primary care providers, that can be very frustrating, that you don't have enough time with someone to get the decent information. And that's where I think there seems to be so much confusion around fertility and infertility, is because, one, the conversation you need to have with somebody is very personal. You're asking about their sex life. You're asking about how often they're trying. You're asking about their partner. You're asking about their periods, their menstrual patterns, their symptoms. There's a whole hour in that one warm-up chat that you would need to have to really start to crack away at whether there's an issue, truthfully, whether they need to be tracking ovulation or understanding their menstrual cycle in the first instance, and what that threshold of their education may be. And then thirdly, whether they need to be getting help. And that's, I think, what we hope to enable people to do is, one, if they want to just go for secondary treatment after having a fertility test, they can. But two, they could just bring their results to a GP.
What tests should the GP be, so a couple, I'm just thinking, because that's really shocked me that Black women come later on.
Well, when we look at time for our cohort of women who are actively trying to conceive, those who are Black women are trying to conceive for far longer before they go for help. Sometimes 3-4 years they're trying to conceive before they finally embark on a decision to do a hormone and fertility test with us nowadays.
Thing that you've said that, because I see that in Pakistani and South Asian women as well, that they will try and try and try, and they'll put a lot of things down to the fact that maybe I haven't, though, because other holistic things that they can do. So they'll try and maybe do more prayers, or they'll try and do more rituals, because there is a ritualistic behavior that comes with it, especially if you're a community of faith, to try and conceive. So I've even known couples who've said, well, I'll go to a certain shrine and pray to Allah so I can fall pregnant. And they'll try all of those. And that, I think those are the factors that delay them getting pregnant, because there is this concept that faith plays a huge part in your ability, because it's a magical event that happens as a gift from God. And when that hesitancy happens and they come to the doctor, what is it that you want the GP, as a molecular geneticist who does this, what tests should we be triggering off once they actually finally make it through the door?
I think the first, I think it's reliant on questions that are dependent on information that I think you, as a GP, you should first and foremost be asking about regularity of cycles. I think also patterns in attempts. What we've found is that many people will come to us and say, I've been trying for a year. And we say, have you been, I guess, having sex during your fertile window? They say, no, we don't want to really ruin things. We just want to let it happen naturally. And the times that they're having intercourse are not actually coinciding with ovulation, and therefore their ability to conceive. So many of those months could actually be really nothing to do with infertility, but lack of education around when is your fertile window. And so that, I think, is really critical information, because at 1 year is only 12 months. It comes by very quickly if somebody is not necessarily educating. And what we always find is that people say to us, I only learned about ovulation and I only learned about my fertile window when I struggled to conceive, because they all of a sudden had the need to understand, wait, how does this work? And am I doing it wrong? And so often they're not doing it wrong. They just, or there's nothing isn't working. They're just not doing it at the right time. So I think timing is a very important question. And although it's intimate, what attempts, I guess, have you had up till now, although it seems obvious? And we as profession of a scientist and your professional clinician, we tend to overlook the simple details. We're trained to look for complex cases and solutions to complex cases, rather than going back to basics and asking the really fundamental questions to say, do you have regular cycles? If so, when is it that you're having sex? Following on from that, do you have any symptoms? If so, are those symptoms indicative of some of the most common conditions? And then I think that's, to me, it's a piece of detective work. And that's truthfully what fertility has been, is my attempt at triaging every single combination of situation that we could say, what are the symptoms that could be indicative of any one of these conditions? And then therefore, can we test appropriately for that condition based on this person's collection of symptoms, biometrics, menstrual patterns, so that we can kind of get to that resolution much sooner.
It's so interesting that you say that women only know about their ovulation once they're trying to conceive or have difficulty conceiving, because a whole lifetime is set up that from the moment that you start your period not to fall pregnant. And so the education around that is, how can you stop your ovulation? And so when it comes on to the flip side and you're actually planning a family, I think it does come as a bit of a shock, because there is this almost an inherent inbuilt behavior or societal thinking that you will just fall pregnant just like that, whatever you do, and it will happen for you. And then it doesn't happen. That's when the shock comes. But the shock comes because the instant thing is, especially from a cultural point of view, I sometimes find that it's seen as the woman's fault or the woman's problem. What are your thoughts?
This is something that really bothers me. I think even in the last 15 years, that narrative, or that the number has changed. So it went from being, well, 30% infertility is male factor to maybe 40%. And now it's like, it looks like infertility is 50-50. And what's more is that as we see an aging demographic of first-time parents, very often it's neither one nor the other that is to blame, but a combination of two of them coming together with lower fertility than they would were they of younger age. There are so many staggering statistics around male factor infertility. The first that really I find so shocking is that 50% or male sperm counts are 50% what they were 30, 40, 50 years ago.
That in sperm count that's decreasing.
Sperm count is radically decreasing. It's almost half what it was 50 years ago. And there's many reasons for this. You might say that it is our environment, our stress, but there are a lot of things in the environment and endocrine disrupting chemicals within our, I guess we have polluted environments. We know that there are links to pollution. And this has a genuine effect. It's also a big link with weight and poor diet. And what amazes me is the emphasis always on female fertility and our need to do something, our need to change our lifestyle, our behavior, our diet, our consumption in order to improve both people's chances of conceiving. And in fact, we are born with all the eggs we'll ever have. That's an unfortunate thing, because our egg reserve is dropping every month. So much so that we have about 86% of our egg reserve is gone by the time we're age 30. And there was a time where 30 would have seen as an older age to have children, and now it's seen as almost young in many places. But our exposures and our egg quality is, I guess, we're throughout our life, it's exposed to whatever we are. With sperm, a new sperm is produced the life cycle is 3 months. So within 3 months, a man can radically change not only the quality but the quantity of sperm by making very subtle lifestyle changes. And we've seen this through multiple studies, even with men who've undergone, for example, bariatric surgery, and the change in the genetic landscape even of their sperm post bariatric surgery. In other words, tummy, not a tummy tuck, when they cut your tummy, not your tummy, but
gastric sleeve, is that what you're talking?
Yes, thank you. It's late on a Friday. A gastric band, yes. And just that restriction in diet and the change in quality a few months later is actually staggering. So why we don't invest more in the conversation to say, actually, a significant amount of change can happen when men engage on preconception health, and the combined power of both in that relationship coming together to say we together are going to make a change in our diet in terms of what and BMI.
I think that's a staggering statistic, that infertility is not just a female factor, it's a male factor as well. It is really 50-50. Because when I was at medical school, we would say, well, investigate the woman first for PCOS, endometriosis, see what her cycles are. Is it primary ovarian insufficiency that she's got? And we would just say to the man, okay, go off and do a sperm test, and that's about it, but not really look at all the factors that will affect male infertility, like you say, weight, diet, lifestyle, all of those things that would impact the quality of the sperm. The fact that sperm count is decreasing also within and the norm is, well, I'll just fall pregnant like that, is something that's going to come quite as a shock to the listeners. I wanted to pick apart some of the data that we have been looking at, because, and also that links into the first bit where we started about how later Black women come. What is the data showing us about infertility and Black communities? Is there, do they have a far less success or far more success in regards to conceiving, or when they go to the doctor, if they get the right appropriate treatment?
So we're running a research study at the moment that is enabling us to really tie into how we understand individual journeys, irrespective of your background, and that the statistics around individual ethnicities and backgrounds is very important. I think it's one of the biggest motivators for me, is possibly because of because I'm a geneticist and I see that everybody is so individual based on their DNA, that I find it so shocking that we treat everybody the same. But what's unfortunate is that our treatment pathways, our treatment cycles, our culturing of embryos, of oocytes, they've all been generated, well, primarily on mouse eggs and embryos, which is not a good proxy for human embryos. But the majority of the statistics are around white couples. And that is unfortunate that we do not look into data around different ethnicities. A recent paper that's just come out has shown that Indian women have higher AMH than their Caucasian counterparts. Why?
Just for our listeners.
So that's anti-Müllerian hormone, and that's a hormone that is essentially secreted by each of the would-be eggs in your ovaries. So if you think of it as a good proxy marker for your general fertility, the more eggs you have, the more AMH you have that's expressed. And when you think that the NHS criteria for free funding for IVF is contingent on a number of factors: your BMI, previous parity, whether you have any children, whether you smoke, but also your AMH. So when there's a cutoff, your AMH, a cutoff to say below this certain level, the NHS won't fund you. And we're looking at this as saying, well, actually, two different people with the same level may have very different meaning for them. Or is it that we've set these reference ranges for one set group of people? So this is something that really we feel quite strongly about, is that each individual case should be dealt with, especially when we know the known prevalence of, for example, fibroids is much higher in Black women. So each individual case needs to be treated much more differently.
And therefore impacting their fertility.
Impacting their treatment. And I don't mean that from a treatment from a medical perspective. I mean that from a person perspective. How they are treated as individuals is going to be impacted by our set of standards, which are not standardized to each individual.
A really good question that just turned up, actually, and I thought I'll throw this to you, because one of the questions that one of the viewers just said is, how do you have one child and then have difficulty conceiving your next one? Because that's something that I see a lot in my patients as well, and that's a common question, but also something that, again, I think impacts a whole wide range of communities as well.
Secondary infertility is actually so prevalent. 1 in 3 will exit their fertile years with fewer children than planned. That sounds a little bit strange to get your head around, but 1 in 3 of us will plan to have more children and have fewer than we actually anticipated. Many will say that's because they had a nightmare child. But when we look at our general demographic of people approaching motherhood that bit later, it means that the second time around we are that bit older again. When we look at infertility, one of the biggest now, probably the biggest cause of infertility, female factor infertility, is age-related. The fact that we are now assuming that we are able to have children later in life is one of the biggest lies we have been told. I was going to say it's one of our biggest flaws is our assumption, but it's actually a lie that we've been sold for so long. There's 2 lies we've been sold. One is that we can get pregnant very easily, and we will. And so we're terrified of it from a young age. And the second is that we can have babies till we're 50. And both of these that have really permeated the media, because we see and hear and read about celebrities in their 40s having children, no mention of how the conception occurred, whether IVF was needed, whether in fact donor eggs were needed, whether a surrogate was needed. It's quite shocking, really, when we look at even the statistics on egg freezing, and the commonest age for egg freezing is 39.
Wow. Okay.
And
I thought it was younger. I don't know why I thought it'd be a lot younger.
The most common age that women freeze their eggs is age 39. And I guess it's that fear of turning 40. But we need to be educating women much earlier about their reproductive ability so that they can actually know and plan. Again, this is part of our ethos at Fertility, is if we plan our career, we plan our finances, we're aware of all of these metrics that significantly impact our lives, why wouldn't we plan and investigate our fertility from a young age, especially when so many reproductive health conditions are so common and they can affect and do affect our fertility.
So we've tackled so far about the fact that people should be coming to the doctor or a specialist to talk about their fertility, even when they're starting out. So as a new couple, if they're planning to have a baby, come together to a consultation. Look at the risks that could pose in you being able to fall pregnant.
Yeah.
Look at your fertility window together. So when is the best time to have sex so that you're having enough sex as well in order to have a baby. And then if it's been more than a year and a half and you haven't conceived, go and see your doctor to have a discussion about further things that you could do, maybe investigations. And we've talked about the cultural hindrances that happens. And I wanted to pick on a lot of the cultural hindrances, if that's okay, just to draw that out. Because I think that the interesting thing is like you say, when you are talking about fertility, you're going into the individual's bedroom, you're talking about their sex life. And that's such a taboo anyway. We don't want to talk about it. The thing that happens culturally, and this is what I see is that if you are having difficulty conceiving, there's a real shame attached to that. It's almost like you failed as a person. Your thoughts?
I think that is a systemic problem that is in so many different cultures. It starts with the individual, and I do think this shame is hopefully changing as people are opening up conversations. We have no choice but to start opening up conversations. 1 in 6 are infertile, 1 in 7 in some countries, but it's
1 in 6 are infertile. How come I didn't know that?
Exactly, 1 in 6 heterosexual couples are infertile.
Mm-hmm. Wow,
Shocking.
That should be something that we
feel like forcing these conversations up because so many people, and I guess it's my whole world, so I'm privileged to hear people's stories, but also heartbroken to hear so many stories of people who said, I wish I knew. Why did nobody tell me? Where is this information? Why is no one talking about it? And so that's what we're trying, is to talk about the rate of infertility.
Well, one of the viewers has just said that, girls and boys should be taught about their ability, reproductive ability at school, and told about fertility rather than the other side, which is just all about contraception. And that's about not to fall pregnant. I guess that comes from this sort of cultural views, is that we had a high teenage pregnancy rate.
That's exactly it. Yeah.
In the UK. The other cultural things that I get is that we talked about already, that how in some cultures, especially I find this in the South Asian culture, that falling pregnant is purely the woman's fault, or it lands at the woman's responsibility. And we've tackled some of those factors already. And I guess one of the things that, and actually it's just come up on one of the viewers, is saying there's a lot of myths around IVF and egg freezing and what that entails.
Yeah.
Your bread and butter, this is what you do. So explain, how complicated is it, egg freezing? There's obviously some available on the NHS.
Yeah.
And a lot of people think that they have to go privately. So cost is a huge factor when it comes to assisted pregnancies.
Yeah. So I think there's 2 things to talk about there. One is availability on the NHS. So egg freezing is only available on the NHS for those who have cancer or a medical reason. So it's not, what's called social egg freezing is not available. Social egg freezing being defined as somebody who wants to preserve their fertility for personal reasons. But the other eligibility in terms of NHS funding for IVF cycles, we've just, again, research is our real bread and butter, but we have looked into the eligibility criteria of all of the different care commission groups across the UK to see just what percentage of people who approached us were actively trying to conceive and how few of them would have been eligible for funding. And it's a point that you just made about trying for a year and a half. What we've realized is that is a really unfair metric to tell somebody to wait a year and a half when the majority of them after that year and a half would still not be eligible for funding for IVF. And that's because of all of the different loopholes we have to jump through and thresholds by which you have to meet. And if AMH, the level of your level of fertility or proxy for your fertility, is dropping in that year and a half, well, in a year and a half, you've actually reduced your chances of being made eligible, and you've certainly reduced your chances of being, I guess, conceiving naturally. So to me, I don't think anyone should wait. I think you should absolutely wait before you get treatment. But in terms of investigations into one's fertility, that should be done immediately. I think everyone should understand what the journey they're embarking on before they go for it, because otherwise it's a harrowing and lonely journey, wondering. And when it comes to IVF or egg freezing, essentially what the process involves is an investigation. So for anybody who would be approaching an IVF clinic, I would say go to Fertility first. This isn't just a plug for Fertility, this is a plug for fairness in price. And to me, I find it unacceptable, some of the prices that somebody has to pay at a private fertility clinic just for an investigation into their hormones. Built Fertility to do is to say, I don't want to go to a clinic. I just want to know where I'm at. Am I okay? What are my hormone levels? What are my symptoms? And so that can be, over £1,000 just for that initial test. And that's what the process will involve. So I just want to do a side by side. The process will involve firstly asking you some questions and testing your hormones. And the next part of that, depending on your levels of hormones, would be working up what's called a stimulation protocol for the woman. So again, this is a very much more taxing journey for a female journey. The male will produce a sperm sample. It will be analyzed. The female will undergo, the woman will undergo a stimulation protocol, which it basically, the best way of describing it is saying that in any given cycle or period or menstrual cycle, our hormones are producing during the first phase of the month, right after your period, we kick back into this cycle of producing enough hormones so that the eggs in our ovaries start to become mature. And typically then only one would be released. And in an IVF or egg stimulation cycle, we're giving the body additional hormones to mature as many of those eggs as possible. So then we can do a trigger shot. What this means from the personal perspective, what you're going to be doing every day, you're going to be sent home with a box of needles and you're going to have to inject every single day. So that, I think that the preparation part of going into this journey can be the most important part, mentally preparing yourself for what your body will physically go through and what you'll psychologically go through in having to inject yourself. If we break it down from a simple time perspective, it can be quite quick, actually. It can be that you do this process within a month or 2 weeks, even depending on the stimulation cycle. And I guess the parameters that one has to prepare themselves for, again, like the physical, what will I physically have to endure? What will I mentally have to endure? And then what will it be doing inside my body? And I think that's the biggest thing that anyone can do, is prepare themselves by understanding about that process and what their body will go through. So you're not going into it blind thinking, I'm so vulnerable injecting myself. You are going to feel vulnerable, but knowledge is power. Every time, knowledge is power. And that can, and we know that can make people feel a little bit more braced and strapped in for the journey.
So part of that bracing and strapping in for your journey, I wanted to tackle some myths, and I think we'll end on that, because there are some weird and wonderful myths I hear. So we'll run them through really quickly. Number one, the biggest myth I hear is infertility is linked to cancer.
I will never say anything is not true, and I would never be disrespectful of anybody's beliefs. But factually speaking, when we look at evidence, infertility is not a cancer of an individual. And I know that is the narrative that is explained, is that infertility is like a cancer of the body. But there is no links with infertility and cancer. I think that's definitely a damaging mental and physical statement that people make.
Yeah, I'm so glad you've tackled that. If a woman doesn't have babies in her lifetime, she's at high risk of getting womb cancer or endometrial cancer.
Again, this is something that ironically speaking, there was evidence previously that women who did not conceive, and this was studies that looked at nuns, and that they had a higher risk of breast cancer, but there is no known links with a lack of conception and womb cancer. And it's very damaging to, I guess, put that additional pressure on women when they haven't conceived, or for that matter, if they have no intention or desire to conceive. There are so many women
choice to be childless, and that's absolutely fine.
Wish to have a family, and it's their body, their choice, and it's absolutely there's no way that should be linked to any stigma or in a heightened fear.
So this is a myth I hear often, and sorry, I don't know why that fly came on my head just then. A common myth that I hear that as long as the man ejaculates, then he's deemed fertile.
Okay, I'll bring anyone into the lab to show them a sperm sample or an ejaculate sample. So an ejaculate can have anything from it's said that the normal sperm count or within range sperm count for a healthy man is 60 million sperm per milliliter, and the average ejaculate is 3 milliliters, depending on the days of abstinence. But there are many times we will look at a sample and there are not any sperm within the ejaculate. What's more, sometimes you can have many sperm within the ejaculate and none of them are really moving. So there's different parameters to even the sperm count. There's the motility, how much are they moving, and are they moving in the right direction? So again, we sometimes look and we see big ejaculate, sperm that are going in circles, some that have two tails, and so that is definitely not true that and it,
Good one. And I was going to ask this: putting your legs up in the air, does that assist fertility?
No, it doesn't. No, it doesn't. And then I can
laugh because that's such a common myth.
Even when I laugh, because I can relate to anybody's desire to improve their chances through and make gravity work for them. But again,
when Phoebe tried to fall pregnant by having assisted pregnancy, she put her legs up in the air.
Exactly. But honestly, it's weird how sometimes comedy is taken seriously because we learn so much from what we see on TV about the conversations that nobody's going to tell you about the conversations or tactics that they have around getting pregnant. It's one of those things that people rely on, therefore tradition, and those are the conversations that get handed down to say, well,
yeah, that's good. The other thing that is a real big myth: if you have an orgasm, then you'll definitely fall pregnant.
Which one? We know if a man has an orgasm, you're more likely to fall pregnant anyway. Ironically, I've also heard stories that ovulation can be induced by an orgasm,
yeah.
But by no way is I'm sure that there are physiological effects that an orgasm has in terms of your hormones. It releases different hormones. Whether or not that will get you pregnant is unknown. Nobody's ever done a study on everyone who got pregnant and said, was it an orgasm?
Okay. Are there any other myths that
there are many people who've had plenty of them and definitely have not gotten pregnant. So
are there any other myths that I might have missed? Because those are the list that I made.
There are there's I guess sometimes they're not necessarily myths, they're cultural barriers that we see, that because of cultural traditions people might be missing their fertile window. We've had many from Orthodox Jewish communities who because they ovulate early, in their period of time that they are not allowed, or they're preventing I guess sharing a bed with their partner, they are therefore missing their fertile window because of this period in between. And I think again that's where statistics unfortunately can be very damaging, because we all are expected to fit within this 28-day cycle, ovulating at day 14, and when religious rules or traditions prevent you from being active, sexually active at that point, you're going to miss out no matter how many times you're trying. No, I mean, I think we could have an entire evening's worth of people contributing their stories and their the things that they've been told. It might be actually quite fun for us to do, is for people to contribute the things that they've been told during their journeys or by their mothers or grandmothers, so that maybe for once and for all we can actually collect them all and say, here's our compendium of
exactly
like the alternative Google, right?
There are so many, but thank you so much, because I'm just wary that I'm taking up time as well, but you've been an absolute star. I mean, I knew you would be, but I just wanted to round off our conversation just so, because I think it's always nice to tie it up so that we've got 3 learning points. Number one if you're trying to fall pregnant, have that conversation about what the best ways to go about it with either your GP or somebody in the know that you can have a discussion with, because you don't want to wait and wait and wait and be out of the window period to have treatment if that is something that needs to be offered to you. Number two, your lifestyle really plays a huge factor for men particularly, which I think has become a real shock, because we realize 1 in 6 heterosexual couples will be infertile. So the lifestyle factors are going to be really important in when you're trying to conceive later on. And yeah, have as much sex as possible. I read that out at the end.
I was like, did I say that?
But sex in the fertile window is what you said.
Sex in the fertile window, exactly. Yeah, yeah, definitely a sex in at the right time.
Thank you so much for just a lovely conversation. We'll post bits of this, hopefully chopped up on social media. So if you missed it, you can watch it back.
All right. Thank you. And thank you for bringing me here to talk about these things, but also thank you for opening it up to your perspective and the questions that you hear. I think we often talk about general topics, and it's important to talk about.
Yeah, of course. This is such an important subject, because there are so many couples who struggle and they feel so alone. So I'm so pleased we had this time together. Thank you so much. Have a really lovely evening. Bye, everybody. Bye. Thank you for joining us.
Bye.